Medical Specialists Associates, making medical education more accessible.
Hi, my name is Christopher Voscopoulos. I'm president of Medical Specialist Associates. I'm a board-certified critical care doctor who practices primarily in the United States. And here our focus of Medical Specialist Associates is taking academic information and integrating it into clinical practice in a way that is more practical for the average practicing critical care physician. I'm luckily enough here joined by Dr. Nazir Habib, who has many years of experience and wisdom, and I always enjoy getting his perspective on topics. I am going to let him introduce himself, and then we're going to talk about the use of high-flow nasal cannula in COVID-19. Dr. Habib?
Thank you, Chris, for the introduction. Yes, I'm also board certified in internal medicine and critical care medicine. And Chris and I have enjoyed many years of working together in the ICU. And as he said, our focus is to try to help people apply some of the scientific tenets in our bedside management of critically ill and injured patients.
So Dr. Habib, COVID-19 is still an ongoing issue, and we really don't know where we're going from here. I mean, at the time of this recording, we're in a lull, but we've been in lulls before where we had surges, and management of this disease entity is still paramount in our profession. So one of the big topics is the preferred use of high-flow nasal cannula in COVID-19 over things like CPAP or Bipap. Can you tell me a little bit about why is that?
Yes, thank you, Chris. That's an excellent question that keeps coming up as we talked about earlier. And I think that pretty much everybody is recommending throughout the world, after we've had many months of experience with COVID, to go to high-flow nasal cannula initially before intubating the patient as the preferred method of delivery of high concentration oxygen. And there's many reasons for that, but just a couple of main things is that high-flow nasal cannula is obviously much more comfortable. You can eat, you don't have to sedate the patient as much, and it actually washes out the dead space, reduces the dead space, and also increases the functional residual capacity by 25%. So there are many advantages physiologically as well as for patient comfort that we use high-flow nasal cannula, and that's why the professional societies recommend high-flow nasal cannula as the preferred mode.
I think just a little bit about high-flow nasal cannula. I'll just go point by point and give you an opportunity to comment on it. I think one of the misunderstandings for high-flow nasal cannula is that because people have their nose and their mouth exposed, there is this impression that high-flow nasal cannula can aerosolize COVID-19 more than, say, something like Bipap. But really, that is not the case because my understanding, and you can correct me if I'm wrong, the very high flow rates entrain oxygen in the back of the throat, almost making it a little difficult to breathe out. And that's what increases that functional residual capacity by having that CPAP that we'll talk about in a little bit. And so there's actually less exhalation in the air. And it's actually Bipap that causes far more aerosolization of the disease. Is that your understanding as well?
Yes, absolutely. In the studies, this has been borne out that actually nasal cannula, as well as CPAP or Bipap, has just as much aerosolization as high-flow nasal cannula. They've studied that by using petri dishes and molecular science. So you're absolutely correct. It's quite safe in terms of dispersion of the COVID virus.
And other aspects of high-flow nasal cannula, of course, as critical care doctors, is we have to look at the global treatment of the patient. And one of the pillars of that global treatment, especially in something like COVID-19, where patients can be sick for weeks to months, is adequate nutrition. So it's my understanding that that gastric feeding with, say, an NG tube is really contraindicated in things like Bipap because you can have entrainment of air and then ultimately regurgitation and then aspiration. But you can feed on high-flow nasal cannula. Is this correct?
High-flow nasal cannula is far superior in terms of getting patients to talk, eat, communicate, sleep better, get better sleep, less requirement for sedation, less agitation, and people pulling their mask off is a common problem. The high flow, it's very important. I just want to point out, Chris, is that when you initiate high flow nasal cannula, you always start at 60 liters. I often see patients on 100% oxygen getting 10 liters of flow, and that is inadequate. The reason being is that the high flow at 60 liters should be left there as long as the patient tolerates it, because it provides some degree of PEEP. Generally, 60 liters will give you about 5 to 6 centimeters of PEEP. And so that's very important, not to lower the flow rate down until the FiO2 is down to about 50%. I like to see RTs avoid weaning the high flow down until the FiO2 is down to 50%.
So this is a really important point, because you had mentioned about recruitment and increasing functional residual capacity. As we get older, we all naturally close the bottom of our lungs. And so high flow nasal cannula has that attribute to where every 10 liters of flow is equivalent to approximately 1 of PEEP. And so you had mentioned, starting people off on that 60 liters, which would be approximately equivalent to 6 of PEEP, and then they have that ability to recruit. You also have high flow nasal cannula, which can go up to as high as 80 liters, and then they would have up to 8 of PEEP. But in reference now, say we're on high flow nasal cannula, and we'll transition in a moment. We'll talk about how to assess how someone's doing on it with something called the ROX Index. But before we mention that, is there a time where maybe someone's not doing so well on high flow nasal cannula, and we would consider a trial of CPAP or Bipap, and when might we consider doing something like that?
Yes, I think as we talked about previously, when you use non-invasive ventilation, okay, there are 2 modes there. There's Bipap and CPAP. If you stick with CPAP, you can move to CPAP if patient looks like they're failing high flow nasal cannula. They're already desaturating. The patients that I might consider might benefit from this, or especially the obese patient or patient who already have sleep apnea. I think definitely in those patients, I would try a trial of CPAP, but generally you want to start at 8 centimeters of PEEP and probably not exceed 12 centimeters. That's pretty much the recommendations of all the societies. And at some point, you need to decide when to intubate the patient and what would you consider a failure.
And I think 2 points in reference to that, as we talked about that correlation of flow to PEEP on high flow nasal cannula, the 10-to-1 ratio, once you start to go to CPAP at 10 or 12, you really can't go back down to that same level of PEEP, on high flow nasal cannula. So you can find yourself, in an area where you can't walk back. And then other important points, maybe perhaps, that I might have seen is perhaps maybe using CPAP when someone naps, or at night when someone sleeps, could be a little bit more effective. We have to, recall from our sleep colleagues that many individuals are mouth breathers. And perhaps maybe when they're sleeping, if they open up their mouth on the high flow nasal cannula, just as if they had nasal BiPAP or so, they could lose some of that entrainment. And maybe CPAP could be a little bit more effective, again, during naps and sleeping at night. Would you agree with that?
Absolutely. I think that sometimes using CPAP intermittently also gives them a break, when you switch back to a high flow. So they tend to tolerate. And then remember, prolonged use of Bipap or CPAP over 24 hours or more will cause inspissated mucus plugs, atelectasis, dryness of the mouth. So humidification is a huge problem with non-invasive ventilation.
I think now I want to transition towards the ROX Index, which is, from my understanding, a mechanism that we could measure how someone's doing on high flow nasal cannula, which is really important because we want to know when we might have to escalate care. Can you tell me a little bit about the ROX Index?
Yeah, the ROX Index is one oxygenation parameter. As you're familiar with, the PF ratio or the SpO to FiO2 ratio has been a predictor in ARDS. What the ROX Index, ROX Index, stands for is that you're adding the respiratory rate to the SpO2, okay, and the FiO2 ratio. So you divide the SpO2 FiO2 ratio by the respiration rate, which is actually on our website. We've posted this on our website. is an excellent predictor of when you need to intubate the patient. And generally, when you're on high flow nasal cannula or CPAP, you want to check the ROX index at 2 hours, 6 hours, and 12 hours. Generally, within 24 hours, you will have a pretty good idea. The area under the curve for using the ROX index in the recent studies in COVID patients has been 0.75 to 0.8. So you'll be very accurate, highly accurate, up to 80% of the time if you use the ROX index as one parameter of when it is time to intubate.
Thank you for that. Yeah, I recall that during the original publication on the ROX Index before COVID-19 came out, the cutoff numbers were 4.88 for success and for failure 3.85 with a gray zone in between. Now we're starting to see papers more specific to COVID-19. Individuals can reference an upcoming blog on our website where we go over the paper application of high-flow nasal cannula in hypoxic patients with COVID-19, a retrospective cohort study where they looked at use of the ROX index, and their number was 5.55. But I think it's just important for our listeners to know that there is a tool out there, and we're coming to our time limit here. And so in addition to that blog, I also want to remind our listeners that we do have a YouTube video, which is on YouTube and our website, on the use of the ROX index, as well as our guideline protocol that we use in our critical care sites that is available for download if you'd like to use that at your site as well. So Dr. Habib, I really want to thank you for your time. It's always a pleasure.
Thank you very much, Chris. Hopefully this was helpful for our listeners.
For more information, please visit our website at www.med-specialists.net. You can also find us on YouTube as Medical Specialists Associates. Thanks for listening.